Okay, everyone.
Did you get it, Helen?
Yes. Myself. It's loading.
Maybe less music.
Okay.
All right, 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 7, 8. Anybody else still wanting to join? All right, I'm gonna
It
go ahead and
says I'm
start it.
still waiting.
I think I see you
It
here.
says waiting in lobby. What does that mean? I don't
All right,
understand
let's
what that
see what
means.
happens.
Oh, I'm there.
Is it starting for you now?
Okay.
Yes.
Okay.
Yes.
A client at 36 weeks complains of discomfort with irregularly occurring contractions. The nurse instructs the client to do what?
Yeah.
Oh, I didn't hit anything. Oh,
Me neither. There, I couldn't see.
I didn't hit anything.
Did it show you on your screen? Did it show you the question?
Yeah, I just couldn't see the answer. So by the time I zoomed, it ran out of time.
Okay. Um,
Walk
I'm
around places.
but you should also be able to see it on my screen unless you clicked the link and it took you to the game and you're not seeing the Zoom part anymore. So the idea behind this question, so she's 36 weeks gestation. So is she term or preterm?
She's preterm.
preterm.
She's preterm. So we are definitely not in a hurry to let her have a baby unless her body's in labor. She's having irregularly occurring contractions. Do you think that irregularly occurring contractions are probably labor or Braxton Hicks?
Braxton.
Braxton Hicks.
Probably Braxton Hicks. So typically, pre-labor Braxton Hicks contractions will subside with activity. And so having her walk around is going to either see if they are progressing and getting stronger or if they're going to feel better. For her, because it's probably just Braxton Hicks contractions, having her walk around is probably going to make her feel better. So that's going to be a good choice for her.
Okay.
Upright positioning in the second stage of labor causes a 10 to 30 millimeter of mercury increase in downward pressure. Why is this beneficial?
Does it aid in fetal descent?
Are we supposed to be able to press this?
I didn't hit
Should.
anything.
I
It keeps telling
can't.
me incorrect, and I'm not hitting anything.
Leslie, are you doing it on your phone?
No, I'm on this. I'm on my computer.
Oh,
I'm on my phone, but I still can't have access to clicking anything. I just see the questions like from
I
professor.
got it right, and I didn't click anything, so I verbally got it right.
So hold on
oh.
then.
What?
Because I really thought I had also fed this game into Kahoot, but I sure don't see it. So because I feel like this platform is clunky. Hold on, let me look. Exam 2. I did it for exam 2, not for exam 1. Exam 3.
Funny day.
Nope. All right. That's all right. We can just call it out. You can see the questions though, right?
Yes.
Okay. So for this one, the upright position is going to help aid in fetal descent. Okay, it's going to help bring the baby down. This is good. What is this talking about doing it in the second stage of labor?
As you go from 10 centimeters fully dilated to the birth of the baby.
Mm-hmm. Yep. And so having your patient push, so second stage is when we're pushing, right? So having her push when she's in this more upright position would help with bringing the baby down. So like squatting. Sometimes women can push standing. It's going to help with descent. When teaching non-pharmacological pain management, the nurse educates the client about a technique to prevent painful stimuli that's entering the brain. This is known as what?
Focus breathing.
Gate control
Gate
therapy.
control. Gate control theory.
This one's gate control theory.
Gate control
So
theory.
the way this works, does anybody want to explain how gate control theory works?
Yeah. Isn't it the like theory that the brain can only take in so much stimuli? So if you divert it with like good touch, it helps eliminate that pain.
Right. Yep. So there can only the idea behind it is there can only be one nerve impulse on the nerve root fiber at a time. And so if we put positive impulses on there, then the negative or painful impulses aren't all making their way to the brain. It's like closing a gate. Okay. So what might work for this? What kind of positive impulses could we create for gate control?
Back massage.
Mhm. Massage is a
Bathtub.
great one for it. Yep. Things that stimulate positive chemoreceptors in the brain. So massage is great for it. Also, like I'll show women, like if they sit on a ball and they rock, it stimulates the sensitive nerves in the insides of our thighs. That also, it also is like a form of massage. I'll teach the partner to massage their palms or their feet. So a lot of these kind of touch things help with this whole gate control theories idea. A nurse working at a prenatal clinic is providing education to a client who is pregnant and the client does not like milk. What is a good source of calcium that the nurse can recommend?
Okay.
Okay, so dark leafy greens and chia seeds are good for dairy. Okay, if we have a patient that like their prenatal vitamins are a good way to supplement, but we don't want them to rely on that for all of their needs. So encouraging them to eat things that are high. So this greens and dark green vegetables and chia seeds are good for calcium. Salmon's good for like DHA. So this would be something separate.
Okay.
Which
Let's
is
see,
not a
fishes.
probable cause of intrauterine growth restriction.
Balanced diet high in carbohydrates. Yeah.
Yeah. So all of these other things are things that could cause intrauterine growth restriction. What is intrauterine growth restriction?
That's when the fundal height is not where it's supposed to be, right? Or that's just a
So
sign of it.
that's one of the things we can see for sure is the fundal height would be less, right? So when we measure fundal height, what measurement are we expecting?
At 20 weeks, it should be around 20 centimeters, give or take two.
Yeah. So typically if you had a lower number, so we expect the number on the fundal height to be within two, right? So similar to the gestational weeks. If you had a number that was less than that, more than 2 less, so like if we measured her at 36 weeks and she measured 33 centimeters, that might be a concern that we have a growth restriction. But what actually is an intrauterine growth restriction?
Is it where the baby just can't grow? Like they're just
The
being
baby's not
restricted?
growing. Right.
Yeah.
The baby's not growing in the appropriate amount that we would anticipate. And so then we are thinking about, well, what could affect the way the baby's growing? And a lot of that is caused by things that can cause a vasoconstriction. Because if she has vasoconstriction, like chronically, we're affecting the nutrients coming through and the oxygen coming through to the baby over time. And so that can cause our babies to be smaller. So intrauterine in the uterus growth restriction, they're restricted, they're not growing at the appropriate rate. And it's usually things that cause vasoconstriction. So smoking is a big one for this. Preeclampsia is a big one for this. But if we're eating a healthy diet, that wouldn't cause it. Which is the best way to support a laboring client coping well during contractions?
Speak to her between
Between
contractions.
contractions. Ask her to rate her pain.
Yes.
Okay, speak to her between contractions so as not to disturb her focus. If she's coping well with her contractions, do we need to ask her to rate her pain?
No,
Do we need to offer her an epidural?
no.
No, we need to let her do her thing. She's working it out, right? So, the thing with this is that when they're really focusing and breathing through their contractions and they're doing a good job, we want to continue to promote that and encourage it. So, we can offer, you're doing so great. We offer reassurance. You're doing such a great job. But unless I definitely need something from her during the contraction. Like if her baby's in the middle of a big decel, sometimes I need to make her move, which is horrible to ask her to do in the middle of a contraction, but sometimes we do that. But unless I need something from her, I don't want to break her focus. I want to let her breathe through her contraction or chant or hum or whatever that's working for her. And then in between, we can talk.
So I have a question about the epidural one.
Yeah.
What medication were we told to not give once they're past a certain stage of labor? Was it just like opioids?
Yeah. So opioids, if they are close to delivery, the thing with opioids is that they cross the placenta. They go into mom's bloodstream, so they cross the placenta to the baby, which then, if you think about a side effect of opioids, what's a side effect?
It sedates you.
Yeah, sinus depressant.
Question.
Yeah. And so it can cause respiratory depression. And so if she's really close to delivery and we give her something that can cross the placenta to the baby, I don't want to cause respiratory depression for a baby that's about to deliver. Okay, so that's the one. If we're really close to delivery, we won't give her like fentanyl and stuff like that, or we try
Okay,
not to.
got it.
Yep, that's a good question. The thing with an epidural is that a lot of people believe, oh, if we don't get this epidural going, then she's going to miss her opportunity. Unless a baby is actively coming out of her body right now, we usually can still do an epidural. Okay, and I've seen some women who have tried to be unmedicated and they get to a point where they're like, I just can't anymore. And they maybe are even could have been pushing for a while. And they're like, I've had it. I can't. And we've done epidurals even then. Um, if it's a first baby, sometimes they'll push for several hours. And so they can get an epidural pretty much whenever. A nurse working in a prenatal clinic is providing education. Oh, we saw this question already.
Yes.
Oh, the answers are different though. All right, so she doesn't like milk.
Survive.
She needs to eat calcium foods. We're gonna go for
Survive.
dark leafy green veggies. Yep.
Mhm. Okay.
The nurse notes the presence of accelerations on the electronic fetal monitor tracing. What is the most appropriate?
Wait.
Document.
Reposition.
Acceleration. Well, let me see.
Okay. What do we think about accelerations? They're good or they're concerning?
They're good.
Yeah, they're good.
They're good. So if we see something on the tracing that is not concerning, there's nothing to do, right? We don't need to notify the provider unless we're like, hey, guess what? We have accels. We could say it as a great thing, but they don't need to be notified. We don't need to reposition and check the monitor for fetal heart tracing changes because what we're seeing is reassuring to us. And we don't need to take the vitals and tell her bed rest is needed to conserve oxygen. We just need to document the finding and reassure the mother that this is good. Okay. And this is going to also be true. There's one decel that also I would document the findings. It's not necessarily like we also can reassure the parent, but it's not concerning. So for our decelerations, we have a couple that we would want to intervene, and we have one that is a normal finding. Do you guys remember which normal finding decel there is? Variable is not quite a normal finding. Variable is one I'm not as worried about, but it still has the potential to decrease oxygenation to our baby over time with a variable.
Is it early deceleration?
It's early decelerations. What is causing early decelerations?
Remember?
Is that like the cord is not in the right position, so as the mom is contracting, it's putting pressure on the baby?
No,
No.
not quite.
Is it just any movement of the mom?
Hold on. Let's do this. 1 second. Okay, let's look at this for a minute. Looking at the word veal chop, like skip the last column for a second. The word veal, V-E-A-L, and then the word chop next to it, C-H-O-P. Okay, you can then follow it across and it'll tell you what's happening. So with a variable deceleration, we have cord compression. If I have cord compression, do you think that that could affect perfusion and oxygenation to the baby?
Yes.
Yes. Now, the thing with cord compression is it resolves. Pressure happens on the cord and we abruptly see a drop in the heart rate. Pressure releases from the cord and the heart rate comes back up. And when the heart rate comes back up, the baby gets that nice big gush of fluid or blood. And so usually babies do okay with this because that they get that oxygenated blood as soon as the cord pressure releases. And the cord pressure is usually short. It can be caused by a contraction. It could be caused by where the cord is in relation to the baby and they laid on it. It could be because they're squeezing it with their hand. There's all sorts of things that can compress the cord. But remember, guys, that there's that stuff called Wharton's jelly in the cord that helps keep protect the vessels from getting compressed too much. So variable decelerations, I'm not reassured that it's fine, but I'm also not totally worried. Okay, what I might do for this is reposition the mom and see if I can shift the baby off the cord, relieve the pressure of the cord. Okay. Now for the E for veal chop, it lines up with the H of chop and that's early decelerations, which are head compression. So that's what we were just saying. This one is a normal thing that happens as the baby's coming through the birth canal. We get pressure on the head. So there's not really anything we need to do for that, because that one, I can tell the mom, you know what, these little dips your baby's having in the heart rate isn't a sign that your baby's moving down in your pelvis, and that's what we want to happen. And I would document that I'm seeing early decels. I document the finding, but I don't need to do anything else. Accelerations we said are good. Late decelerations are the ones we worry about the most. Late decelerations happen after the contraction starts because we're not getting good perfusion to the baby. So this is a placental insufficiency. It's a placenta problem. So if we look at veal chop, the L lines up with the P for placenta. So then we got to think about, why are we not getting good perfusion? Why is the placenta not doing its job? And the main things that can cause this is mom's position, like supine hypotension, mom's blood pressure, because remember, blood pressure, especially hypotension, affects how she perfuses the placenta. And also she's having a lot of contractions close together, because every time her uterus contracts, it's squeezing the vessels that provide blood supply to the placenta. So that's the late decelerations are the ones that we need to intervene the most. Okay. And so we can do a position change here also. So for variable decelerations, moving the mom is a good thing to do to relieve pressure on the cord. With late decelerations, moving the mom to try to help with supine hypotension to help get better blood flow to the placenta. Oxygen is a choice. It's not a priority intervention anymore, because if I'm not getting good blood flow to the placenta, it doesn't really matter how much I oxygenate it. IV fluid is going to help support her blood pressure. Notify a provider, because that we might need to do a C-section if this doesn't resolve. And then tocolytics to slow contractions down. So this spells out the word point. So the point is we need to perfuse better. No, go ahead.
That we were looking at some of these yesterday, the readings on the right of the screen. That one at the
Yep.
very top with those sharp drops, is that
Yep.
variable deceleration, or is that early decel?
So
Variable.
they're
Okay.
variable. So these ones in this picture are timing with the contraction, but they have that abrupt drop and they make the V shape. So these are variables. Okay, variable decelerations do not care about the timing. The timing is variable. It changes depending on what's causing pressure on the cord. In this tracing, the pressure on the cord is probably happening with the cord is maybe by the baby's shoulder and the uterus, and every time the uterus squeezes, that's what's pushing on the cord. And so it is timing with a contraction, but it looks different. If you look at the other two, they have that kind of U shape where they're more subtle like this, and this is more abrupt, like a drop, like a V. Now, actually, and not something that you guys need to know, but just so that it makes sense maybe in your head, a variable gets to the bottom in less than 30 seconds. And early and late decelerations take longer than 30 seconds. And that just kind of helps us remember that a variable has that abrupt onset and it resolves just as quickly, so it makes that V shape. So the timing doesn't matter for those. Timing matters for early and timing matters for late, because that's how I determine if it's early or late, is based on how it times with a contraction. If it happens at the same time as a contraction, so here early decelerations mirror or happen at the same time, that's this one. See how it starts going down when the contraction starts going up. And it's back to the baseline as the contraction ends. They happened at the same time. The nadir of the deceleration lines up with the peak of the contraction. These are early. This is head compression. This is no big deal. The one below it, the contraction starts and then the deceleration starts. You see, we're like at the peak of this contraction before the heart rate goes down. This is, I'm not getting what I need from the placenta. This is late. Okay, and this is the dangerous one. But when I say what, so we said accelerations, we would document the finding and reassure the mom. And I said, what deceleration is also something that I'm not worried about? It's the early. Because this is head compression. This is normal physiologic changes happen in labor. Okay. But late decelerations need intervention. We have to solve the problem or the baby will become hypoxic. So we'll position change, IV fluid, turn off Pitocin, slow contractions down, support her blood pressure, and get her in a position that is perfusing her placenta well. And if those things aren't working, then they might do a C-section. Okay? Because those are the ones we're the most worried about. Okay. A pregnant client states that her last menstrual period was on 12/1/18. She's been pregnant 2 other times, delivered twins at 37 weeks and 1 day that are 2. She had a miscarriage at 8 weeks. What's her estimated due date using Nagel's rule?
Okay, October.
Weird.
I'm going to stop it and not show the answer yet. So this one is a long story, and there's a few questions, different questions about her. So let's look at it again. Okay, her last menstrual period was December 1st, 2018. She's been pregnant 2 other times. She delivered twins at 37 weeks and 1 day who are 2 years old, and she had a miscarriage at 8 weeks. Okay, what's her estimated due date using Nagel's rule?
September 8th.
You guys agree with September 8th?
October.
Yes.
Yes.
Okay. Everybody know how to solve this? How to figure it out? We feel good about Nagel's rule?
12.
Add 7, subtract 3 months.
Add 7 days, subtract 3 months.
7 days, add a year if you need.
And add a year. Which is a sign that labor may begin soon?
Urgency to push.
I
I
put
think
quickening, but I think
urgency
it's
for
bloody
this
shoe.
means, I think this means urgency to like voiding.
Yeah, I think it's
So
bloody show.
bloody show. Bloody show is not true labor, but it could be a sign that labor is going to begin soon. Because that bloody show either it can be an indication that the cervix is softening, effacing, those little capillaries are starting to break. So this is a sign that labor may begin soon. It doesn't mean she's in labor right now, but she probably will be. Okay. Quickening, what is quickening?
Is that referring to breathing?
The
That's
baby's
the
moving
drop,
down.
isn't it?
Yeah, the drop.
Quickening? Nope.
I thought it was the baby moving down or like dropping.
I think that's
That's
lightning.
a different term.
Oh,
What
it
is
is
the
lightning.
term for if the baby, yeah, lightning is the drop.
Quickening
When
is
the baby
the
drops,
fluttering.
quickening is the fluttering. It's the first
I was-
feeling of fetal movement.
Oh, that's right. It's the butterflies.
Yeah. And so lightning is the dropping or engaging in the pelvis. Okay. But yes, so Leslie's right. The flutters that she feels at like 18 to 20 weeks usually, that's quickening. A woman in labor is 6 centimeters dilated at 0 station and contracting every 4 minutes, and she requests an epidural. In order to limit the risk of this procedure to the mom and the baby, the priority intervention before the epidural is administered is to do what?
Monitor
Heart
contraction.
rate.
IV fluid.
Okay,
Oh,
she's 6 centimeters, she's 0 station, she's contracting every 4 minutes. Is she in the latent phase or the active phase of labor?
Active.
Mhm. She's active. She wants an epidural.
Okay.
And so it says, what should we do to decrease the risk to mom and baby? So why is IV fluid a good choice here?
Because epidural can cause hypotension. And so IV fluid would help with her blood pressure.
Right. So preloading with IV fluid is going to help support her blood pressure and minimize the risk of hypotension. If we give this mom an epidural and she does indeed become hypotensive, how does that affect the baby?
They're not getting enough oxygen.
Mhm. And so what kind of D cells might we see on our tracing?
Late.
Correct. Okay, so we're trying to minimize that. So we're going to give her IV fluid before the epidural. A prenatal nurse recommends folic acid supplements to a pregnant client. Which of the following defects can occur in a neonate as a result of folic acid deficiency?
And bifida.
Spina bifida. Or spina bifida? Let me say it.
It's spina bifida. Okay, it's neural tube defects. So spina bifida, myelomeningocele, anencephaly, all of these things that have to do with the way the neural tube forms and closes are affected by folic acid. So really taking folic acid before she even gets pregnant is best. But starting it as soon as possible is going to be helpful.
Can I ask you a question?
Yeah.
For anencephaly, can
Yep.
that happen even if you have the recommended folic acid?
Certainly.
Okay.
Yeah. I don't know what all the risk factors are for it. It's thankfully very rare. So anencephaly, guys, is when the baby doesn't have all of the brain. They have the brain stem, but they don't have everything, and it's not conducive with life. It's very devastating for the parents, but I've actually taken care of a few families that have chosen to carry the baby, and donate organs and stuff like that. And the whole thing is just it's very sad. There's a lot of things, I don't know all the causes, but the folic acid supplement has been shown to decrease neurotube defects, that falls within that range. But it's not going to be the only thing. But it is truly tragic when a parent has a baby with anencephaly. Okay. Which statement is true about exercise during pregnancy?
Vigorous. It is taught to diabetics to do after, I don't know.
They consider to control too much weight gain. Oh.
So actually the red is the best choice here. So
Okay.
exercise during pregnancy, low impact is good. They should be doing it to feel good, not because they want to lose weight or whatever. Okay, so things like yoga and swimming and things like that are good ideas. We really, though, do encourage diabetic clients to have exercise after their meals because it helps control their blood sugar if they incorporate exercise into their daily routine. I'm gonna let this run a little. The thing I don't like about this platform is sometimes it gets stuck. Which of the following answers best describes the stage of pregnancy in which maternal and fetal blood are exchanged?
Maternal and fetal blood are never exchanged.
Yeah.
Yeah, that's
They're
what I'm
not ever
thinking.
exchanged. Yeah. They're not ever exchanged, guys, okay? So there are times like at childbirth and during trauma and things like that, that there's a possibility that maybe like a cell of fetal blood crosses that barrier, which is why we worry about it for RH incompatibility and things like that. But typically, we're not exchanging blood. So how do we get the nutrients and the good stuff to the baby and get the waste out if we're not doing any exchanging?
Placenta.
Placenta.
It
Yeah.
all happens in the placenta. And so I don't know if I have a picture. I might have a picture. It might be easier to see it than to listen to me talk about it. I'll talk while I'm looking. The thing that happens in the placenta is that we have the fetal capillaries that come into the placenta, and then the maternal blood comes into the placenta. And so then the exchange can happen between the maternal blood and the fetal capillaries by diffusing across. We're not mixing any blood. We shouldn't be. No, I can't easily find my picture right now. But anyway, basically that's the gist, okay? So we can have diffusion and maybe some active transport that moves things around, kind of like the way we move things in and out of our cells, but we're not mixing blood.
I have a silly
Okay?
question. Does
Nothing
the,
silly.
does all the baby's blood as it's growing come from its bones after they're developed, like from the bone marrow? Or is that like just the amniotic? I'm just trying to think about how the baby gets its start in that area.
I don't know that I've ever given that enough consideration to give you a thoughtful, educated answer.
Okay.
I
Yeah.
would say probably.
Okay.
I think that because if I'm just thinking it through, and I mean, you could try to look it up in the book or look it up online, but if I'm just thinking it through, we start with just the cells, right? We start with the sperm and the egg, and then they start dividing and dividing. And as this is happening, we are forming different organ systems. And so I think we also form blood. The fetal heart starts beating really early at like 6 weeks gestation. You start seeing those first flutters. And so there's something to circulate at that point. So I think it's just part of the formation as the cells are dividing, but I don't actually know. But
Well,
I
you
think
said
we
there's
have
more,
it before. Go ahead.
didn't you say there's more plasma than blood
For mom, in
for
mom's
mom?
blood, in
Okay.
mom's body, when mom is pregnant, her body increases its overall volume. And because it's got a perfused placenta. And so the overall volume goes up and the red blood cell production for mom goes up, but the plasma goes up more. And so
Okay.
it causes what we call like a delusional anemia or physiologic anemia because that she has more plasma to red blood cell ratio than she does when she's not pregnant, if that makes sense. But that's not true for baby though. So Jake's asking, well, how is baby making their own blood? And I don't totally know the answer to that.
I mean, it would make sense it would come from the bone marrow since that's where that comes from. And as the baby grows and the bones grow, then it would slowly start increasing on the red blood cells, I would think.
I'm not sure. So Jake, you're gonna look this up, you're gonna research it, and then you're gonna find me on Canvas because I'm in all of your shells. I'm in the email, and you're gonna send me what you find because I want
I
to know
think
the answer.
I think Leslie is the one that asked that actually.
Is that
Now I
right?
need to
Leslie
know.
did. I don't know. I didn't realize that Leslie's voice was so low.
Was so low, right?
I need
That's
to
a
know
great
now.
question. I actually am going to look it up now because I want to learn, but I don't know the answer offhand. And that's what I love about students is you guys are always keeping me on my toes, and I'm always learning because you guys have such great questions. So this is our same pregnant client, okay? She's been pregnant 2 other times. She delivered twins at 37 weeks, and she had a miscarriage at 8 weeks. Now we're doing GTPAL. I'm going to pause it so we can think it through. This, where I pause it before it shows the answer, is probably why the game gets mad at me and it ends up stopping at some point because it probably will kick us out before we're done. So let's think about it. What do you think her G is?
Two.
G2, T1, PO,
Oh,
A1.
wait.
3, because
No,
she's pregnant
3.
now.
Yeah.
She's pregnant
Oh,
now.
yeah. Eight, yeah.
The
Sorry,
twins.
sorry, I gotta keep that for memory.
Then she had twins,
That would be 1.
and then right? So
Yep.
she's pregnant now is 1.
And a
Then she had
37.
twins, so that's a second pregnancy. And then she had a miscarriage, that's a third pregnancy. So do we agree that G is 3?
Yes.
Yes.
How
Yes.
many term deliveries?
1.
1.
1. The twins count as 1. Is it term for sure?
Yes.
Um,
Is it 37?
37.
Yes, it's 37 weeks. So yeah.
Yep, it's term for sure because it's greater than 37. And then, so then she's got 1 term delivery. How many preterm deliveries?
0.
No preterm deliveries. How many abortions?
1.
1,
1. How many living children?
2.
2.
2. So it should be green. And it's green.
Yeah, I got 3 because twins is 2, and she's got 1 already, right?
No, she's pregnant currently. So we're not going to count that one till after it's born under the living children. So we've got twins that are 2, and then she had a miscarriage at 8 weeks.
So just 2.
Just
Quick
2 for
question.
the living.
And is this score, this GTPAL score, is that just for the caretakers, so like the facility to know like any risk?
It gives us a good picture of her obstetric history.
Okay.
And so oftentimes on prenatals, I see it written a little bit differently. And I talk to my students about how you might also see it without the letters in there, where it might say G3P, meaning parity, 1012, and it's the same thing, term, preterm, abortions, and living. Because if I just told you, if I said, Jake, I'm going to have you take care of this pregnant girl, she is a G3P1, you don't know. You know she must have had an abortion at some point if she's a 3-1, but you don't know she had twins. You don't know anything else unless you have that whole picture. Okay, so this gives us the whole picture, the whole obstetric history. Okay, there's a few times that it's flawed. Like if she delivered twins, but one didn't survive, then in the L it still shows a 1, and so it still doesn't capture that. But so there's a few times it's flawed, but for the most part, this is going to give us the best information at a glance of what her obstetric history is. Yeah.
I have a question on this G on the P, like the preterm. It says from 20 to 37 weeks is referred to as preterm. But if we see 37, it's also considered full term. So what is the difference between the 37 there? One is 37 and greater than 37 is a full term. Greater
Yep.
than 37 is a full term. And the
Where are
preterm
you
is
seeing
20
that?
to 37. Huh?
Where are you looking that you're seeing that?
I'm looking at the numbers that I have.
Okay. So
The numbers that I wrote down before for the GTP.
Okay. So let me show you this real quick. If you're in my class, you've already seen it though, but we'll pull this up for a second. All right. The G is the number of pregnancies.
Yes.
Term, let me zoom in, is greater than 37 weeks. So 37 weeks and 0 days and beyond is term. Preterm is 20 weeks and 0 days up to 36 weeks and 6 days. And sometimes it comes down to the hour. If she's 36 and 6, and then midnight happens when she's 37 and 0, suddenly the baby switched from term to preterm in 5 minutes or whatever. So 36 and 6
Okay.
weeks is the top of our preterm. 37
I
weeks and
can
0
see
days
now.
and beyond is considered term.
Okay. Because there was a video I watched. That was that was when I wrote those numbers down. That was like it was contradicting because it said from 37 and 37. So now this is the right one. I'm going to use this one now.
Okay,
Thank you, man.
you're welcome. Are you guys good on gravidity and parity?
Not really good at parity. If you can just
Okay,
like
parity
explain a
is
little,
our
that would
number
be
of
nice.
deliveries after, or is our number of deliveries after 20 weeks. So on the one we just talked about, she had twins, it counts as 1 delivery.
Okay.
Okay. And then
Okay.
if she's only had 1 baby before, she's a prima para. And if she's had multiple babies, she's a multipara. You can have a patient that is a multigravida and still be a prima para. Okay, she could have multiple pregnancies but only have delivered 1 baby after 20 weeks gestation.
Okay.
Okay. Where'd our game go? On my sharing screen. Oh, it's going to be in the same spot. Hold on.
Okay, I'll go back to the
A woman is 36 weeks gestation. Which of the following tests will be done during her prenatal visit? This is the GBS. So glucose tolerance test, we do this at around 26 weeks, 26 to 28 weeks. Well, it can be as early as 24 weeks. This one is going to be if our patient's not diabetic when she gets pregnant, we check to see if she has developed gestational diabetes. Okay. Amniocentesis is a test where we can actually pull amniotic fluid out with a needle. That one is high risk. It's not common that we do it. We can do amniocentesis early in pregnancy to determine if we have neural tube defects, if we have Down syndrome, things like that. And we can do it later in pregnancy to determine lung maturity if we're going to deliver this baby early. Blood type for incompatibility, RH incompatibility, we would have done it already before 36 weeks. What blood type would mom be if we're concerned about RH incompatibility?
Negative.
RH negative. And we don't know at 36 weeks if her baby's positive. So she'll get RhoGAM usually around 28 weeks, and then we'll test baby's blood at birth and see if baby's positive, she'll get RhoGAM again. But the test she's going to get at her appointment at 36 to 37 weeks is for Group B strep. Group B strep lives in the normal flora. It's not dangerous for mom. Why do I want to test her for it?
Because the baby can get it when it comes out the vagina.
Mm-hmm. And it's dangerous for baby. Go ahead, Jake. What?
I think our professor told us it's linked to higher mortality rate in babies.
Up to 50% mortality rate for babies that contract Group B strep. Yep. So we're going to run this test. We do a swab of the vagina and the rectum, and if it's positive, then we give her antibiotics during labor. Okay. Genetic disorder in which both parents must be carriers of the gene in order for the baby to have a 25% chance of expressing the disorder?
Autosomal recessive or
Yep,
dominant?
this is a recessive. Okay, this is the recessive. If it's autosomal recessive, both parents have to carry it. That means both parents don't have it. This is where like a carrier screening is helpful, where we do a blood test to see what they carry, because together they could make a baby that has like cystic fibrosis or something like that. That's a recessive gene that we don't know that exists without checking because they don't have it. Which of the following clients should the nurse be concerned about regarding weight gain?
Oh, wow. A client who has gained 15 pounds in her first trimester?
No,
How
the
much should she
25
gain in the
pound.
first?
4.
25 pounds in the third trimester, 20 pounds in the second, or 4 pounds in the first. So how much are we supposed to gain in the first?
4.
4. Okay, so 15 pounds in the first trimester would be concerning. 20 pounds in the second trimester. So if we've gained 4 pounds in the first trimester and then a half a pound to a pound a week. So in the second trimester, she could gain 20 pounds and that would be okay because our total for a normal BMI is how much?
25 to 35.
25 to 35.
Calculate
So
that.
20 pounds in the second trimester would be okay. 25 pounds in the third trimester would be okay. 4 pounds in the first trimester is normal, but this girl that's gained 15 pounds in her first trimester, that's not normal.
You said that for the first trimester, you should gain around 4 pounds, and then after for the second and third, it's half a pound to a pound a week.
Mhm. Yep, so think about the first trimester is 12 weeks. Okay. So then the second trimester and third trimester, so if we break them down into 12-week chunks, even though then there's a couple weeks at the end, then we've got 24, 25, 26 more weeks. 26 plus, if they gained a pound a week, 26 plus 4 is 30. So it puts us right in that ballpark. So roughly, that's roughly what we anticipate. If they're gaining more, and I wouldn't think it for this girl in this example because she's in her first trimester having gained 15 pounds, but if they're gaining more weight later in pregnancy, I'm a little bit worried about preeclampsia, like if they're hanging on to a lot of fluid. But it also could be dietary, it could be other things. So it would just require more evaluation.
So the normal BMI is what?
18.5. I can't remember what the low end of it is. Hold on, because I led this one.
24.9.
We can pull it up. Assessment tool to evaluate fetal well-being and assess for potential fetal compromise.
BPP.
Mm.
BPP.
Yeah. So for a biophysical profile, so first, so Anna Marie was correct that so 18.5 to 24.9 is considered normal BMI. I couldn't remember what the high end was. Okay. If your patient, so backing up to BMI for 1 more second, and then I want to talk about biophysical profile. But if your patient is overweight when she gets pregnant, then the recommendation for weight gain tends to be a little bit less. Okay, and if your patient is underweight when she gets pregnant, then the recommendation for weight gain tends to be a little bit more. And I think your book has specific numbers for those ranges. But just kind of thinking that if they're in the normal range, we're thinking 25 to 35 pounds. And the 4 pounds in the first trimester and half a pound a week after that. I think if they're obese, so the BMI is greater than 30, I think the recommendation is a weight gain of 15 to 20, but we'd have to double check the book. Okay, so usually less weight gain if they're obese, more weight gain if they're underweight. So, but the figures we're talking about is for a patient with a normal BMI. So now biophysical profile. This is an assessment tool, as the question says, that evaluates fetal well-being. How do we do it and why would we do it? Anybody know?
I know why you do it. I just don't know how you do it. The reason is because if you take the BPP and it gets a low score, then it's going to determine if you want to go ahead and induce or do a C-section because it's going to be low chance of viability.
What was the question? I'm sorry.
So the question on the game is asked what the assessment tool is that evaluates fetal well-being, and biophysical profile was the answer. So I asked, how do we do it and why do we do it? And so Jake is saying we do it because that if the score is low, we're concerned that the baby might not do well, and we would need to maybe deliver with a C-section.
I remember in McGuffey's reviews, like Batman, so you check like the fetal breathing, the amniotic fluid, the tone of the kicking, the what is M? Movement, and then the non-stress test. And then it's 0 to 2 for each one. You don't get half a point. Either they did it or they didn't do it. And then like Jake said, that if you're getting a low score and it might be 7, lower than 7, then you want to, it's like showing an impending death of the baby or something like that. So you want to get the baby out.
I couldn't have explained it better. There you go.
Okay.
That's it.
What does the A stand for in Batman?
Say that again, I'm sorry.
No, go ahead. You know what? You're on a roll. You go ahead and you explain it.
Sorry, what'd you say, Les?
What does the A
You
in
asked about Batman.
Batman stand for?
Amniotic fluid. So, right? Am I
Both
sure?
A's are amniotic fluid?
Yeah, I think if it's low.
Well, there's not two A's.
A's in Batman.
There's no 2 A's. It's B-A-T. It's spelled wrong.
Oh.
It's
to make it
Batman,
work.
but it's
Got it. Got it.
Yeah.
Thank you.
I think I have it right. I can show it to you if I can find it.
Are you doing this by ultrasound?
Yeah. So the way that they are assessing this is by ultrasound. So in my class, we did this related to our patient Abby, who hadn't been feeling fetal movement. Okay. And so she came into the clinic. She did her kick counts. Do you guys remember how to do kick counts?
No.
10 an hour.
Yep.
You just
So
count it.
we daily fetal movement counts or kick counts. We have them count how many fetal movements they feel in an hour and how many should they feel.
10.
10? I think.
10. So we say in an hour to 2 hours, because if the baby sleeps for 45 minutes and the baby just wakes up at the end of that hour, she might not get 10 kicks in the first hour. So we say 10 kicks in 1 to 2 hours.
Okay.
So if they're not feeling fetal movement, that is concerning if they're noticing changes. So in the scenario I did in class, she was 34 weeks pregnant. She hadn't felt her baby move at all today. So she tried laying on her side to assess further. She didn't feel any movement. And so she called the doctor and they had her come to the clinic and they put her on the monitor. So the first thing we'll do is a non-stress test. Put them on the monitor and look at the tracing. Okay, and on a normal non-stress test, we should have normal baseline. What's a normal baseline for baby?
110 to 160.
110 to 160.
110 to 160. We should have what kind of variability? Not everybody's gone over this in class yet this week. Variability is the variations in for the give and take of the sympathetic and the parasympathetic nervous system, and it causes our tracing line to squiggle.
Is it like
These
10 to 10?
variations, well, that's gonna be more our accels, but the variations are going to be around the baseline, and if they're between 5 and 25 beats,
Yeah.
that's
Okay.
moderate variability. That's
Right.
the one that's good.
Okay.
Okay, because babies that are well oxygenated can do this. Babies that are not well oxygenated cannot do this.
Yeah. Okay.
Okay. If the baby doesn't have moderate variability, that doesn't automatically mean something's wrong, because babies that are sleeping also can have less of those variations or minimal variability. So if you don't have between 5 and 25 on your squiggly line or those variations, that's not automatically a problem, but it's not something that's reassuring.
Okay.
Moderate variability is reassuring. So
Okay.
we want moderate variability, our squiggly line, to have variations between 5 and 25 beats around the baseline. We want at least 2 accelerations, and those need to go up at least 15 beats and last at least 15 seconds.
Okay.
And that, with no decelerations, would be reassuring that your baby's doing well
So
for a
all of those
non-stress test
collectively.
collectively.
Okay.
Yep. So if our patient's not feeling fetal movement, so we tell her to come in and we put her on the monitor and we don't see all of that, I'm not necessarily sure her baby's okay. So now we'll do an ultrasound. And the ultrasound is where the Batman part comes in, and I can zoom this down here. So it's missing an A. So breathing movement, amniotic fluid index, tone, fetal movement, and non-stress test, and then they combine to create a score. So like Anne-Marie said, we've got 2 points per category. And if it's a low score, that's an indication of fetal compromise. And we might do a C-section, and I've seen that happen.
Okay.
And we actually had somebody who came in that actually worked in the prenatal clinic, and she was pregnant. She was like 32, 34 weeks. I can't remember now. This exact scenario. And the tracing wasn't good. We did the biophysical profile. She scored a 2. They did a C-section, and the baby's 1-minute APGAR was a 3, which is really not good and really possible that that baby would not have survived if she hadn't come in. So changes in fetal movement or absence of fetal movement is a warning sign, and they should let us know and be assessed. Okay. Well, this is where the game wants to get stuck. I knew it was bound to happen. Let me see what I can do here. Probable signs of pregnancy. I can't show the answers now because it shows which one is correct. What are some signs that are probable?
Nausea.
Objective?
Oh,
What do you think? Oh, sorry, so let's talk about what signs are probable. This asks what are not, but that would be confusing. What are some probable signs?
Anything objective,
Oh,
like
yeah, you're right,
Hedwig
Jake.
signs.
Mhm.
Anything objective, things you can assess. Okay, so examples.
Chadwick sign,
Mhm.
good old, am I saying that right?
Mhm.
Positive pregnancy test.
Mhm. Okay, good. Those are all things we could assess. What are some subjective or presumptive signs?
Nausea, vomiting.
Mhm.
Missed your period.
Mm-hmm.
It's my period.
What about positive?
Say that again?
Monitor.
Ultrasound.
Positive signs.
Yeah, ultrasound.
Ultrasound.
Feeling, seeing,
Good.
so
If I
movement.
can, as the nurse, if I can feel it with my hands, I can hear it with my ears, or I can see it with my eyes. The baby, not what her uterus is doing or anything else. If I can see, hear, or feel the baby, that's positive. Okay. So it could be ultrasound, it could be X-ray, it could be Doppler, hearing the heart tones, it could be palpable fetal movement by me. Not she told me she felt the baby kick. I felt it. Those are positive. So I think this question had Braxton Hicks contractions. Are Braxton Hicks contractions presumptive, probable, or positive?
Probable.
Probable. Positive urine or positive HCG test is probable, and Chadwick's sign is probable. Fetal movement palpated by the nurse is not probable. It's
Positive.
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 Okay, we did this question. We did this question. Same pregnant girl, right? She had her period on 12/1/18. She's been pregnant 2 other times. She had the twins and a miscarriage. How would you describe her gravidity and parity?
That's the one we did earlier, right? With
We
3
didn't talk
pregnancies.
about gravidity, right? But we didn't talk about her gravidity and parity.
Oh. Okay, so she's a multi. I don't know. I got to study these more because this is complicated. But I know it's like a multi because she's had more than one. A
She's
null
had a
is
multigravida.
none. And a null is none, right? And what's the other one?
Prima.
Where she's just had one, right?
Correct.
Her parity be 1, correct?
What do you think?
Yes.
Well, she gave birth to 2 babies, but she had 1 birth.
Correct.
So
She's a multigravida because she's had multiple pregnancies. She's a prima para because she's only had 1 delivery past 20 weeks.
Yeah, that makes sense. Okay.
You got it? Client's fundal height is at the xiphoid process. The nurse is aware that which of the following fetal changes is likely to be occurring at the same time. So hold on and I'll tell you what the choices are, but I'm not going to let you see it. Surfactant is formed in the fetal lungs. Eyes begin to open and close. Heart begins to pump blood, or spinal cord closes. The fundus is at the xiphoid process. What's happening to the baby at this point in pregnancy?
Surfactant.
Surfactant. If the fundus is at the xiphoid process, how far along is she in her pregnancy?
Probably full.
Like full term.
Pretty close,
Yeah.
right? She's
Close
somewhere,
to full
she's got
term.
to be like 36, 37 weeks. Good. So surfactant is formed in the fetal lungs. At 36-week gestation, client lays flat on her back. Which of the following maternal signs and symptoms would the nurse expect to observe?
Hypotension.
Dizziness, because of supine hypotension, right? If
Yeah.
she lays flat on her back, then her baby can put pressure on the vena cava and cause her blood pressure to go down. So she could feel dizzy and lightheaded. And also that affects perfusion to her baby, which is why turning her off of her back or encouraging her not to lay on her back is a good idea.
Professor,
We talked about that. Yep.
sorry, gravida means how many times you've been pregnant?
Yes.
Okay, thank you.
We did exercise. Okay. A woman practices pica. Which is the most commonly associated complication, which of the following complications is most often associated with pica?
Usually it's anemia.
Yeah.
Iron deficiency anemia.
Mm.
We did this one. Here's your question right here, Anne Marie. Gravida refers to which of the following descriptions? The number of times the client has been pregnant is the answer. Folic acid we did. Weight gain we did. Milk, because apparently that's in there twice. Chadwick sign. If the nurse notes the presence of Chadwick sign, what does a Chadwick sign look like?
Bluish.
For the blue
Bluish, pink, purplish.
Discoloration in the cervix.
and vagina.
Okay, and what sign of pregnancy is that?
First. Or
Probable.
probable, yeah.
Yeah.
Yep. Bluish discoloration of the vagina and cervix, and it's a probable sign of pregnancy. Purpose of placental functioning. What's the purpose of placental functioning? What does the placenta do?
Respiration.
Takes out the waste.
Takes out the waste.
Nurse.
Respiration.
A metabolic.
Awesome.
Nutrition, excretion, respiration, storage.
Exchange of oxygen, nutrients, and waste between the mother and the fetus. And we already talked about how the blood doesn't mix, and we talked about all of that. We feel good about the placenta.
Yeah. Especially your filter system, right?
Yeah.
Between mom and baby.
And it's really also the lungs for the baby, because the baby's not using their lungs right now. So it's going to bring in the oxygen and take out the carbon dioxide.
Oh,
Okay. The first perception of fetal movement commonly felt at 18 to 20 weeks. We talked about this, but we didn't see the question. What is the maternal perception of fetal movement called?
Quickening.
The quickening.
Quickening. A nurse suspects umbilical cord compression if
My
which is noted
disadvantage
on the
against-
external monitor. What's that?
Oops, sorry.
The nurse suspects umbilical cord compression if which is noted on the external monitor tracing during a contraction. So what does the deceleration look like if we have cord compression?
Variable acceleration.
Variable deceleration. It has that V shape, abrupt onset, right? And so we suspect cord compression, and what should we do?
Move the mom. Reposition.
Yep, good. We talked about accels. What assessment data can be determined by examining the fetal heart rate strip oxygenation? I don't know if we did that question yet. So the whole idea of the fetal heart tracing and all the stuff you guys are learning related to that is to give us an idea if our baby's well oxygenated or if our baby's in trouble. Okay. So if we have a normal baseline and we have moderate variability and we have 2 accels in 20 minutes, that baby is well oxygenated. Everything else is us determining like on a scale of 0 to totally worried, how worried am I? What do I need to do to get back to the point that I'm not worried? Okay, because it's all about oxygenation for our baby. What is the most common and potentially harmful maternal complication of epidural anesthesia?
Is it hypotension?
Hypotension.
Okay.
And we talked about why we do the fluid bolus, and if mom's hypotensive, it affects the way we perfuse the baby. We could see late D cells. We talked about that one. We talked about that one and that one. We talked about coping in labor. Warning signs of pregnancy. So the nurse would teach the client to report all of these except which one that is not a warning sign. So let me see what they are. Urinary frequency, leaking fluid, vaginal bleeding, or heartburn or epigastric pain accompanied by a headache. Oh, and then urinary frequency. Did I say that one?
Was
this an epidural question? I'm sorry.
Yeah,
the question is, it wants to know, the the nurse would teach the client to report all of these except which
Oh,
one, and
Urinary
the thing that you
frequency.
don't need to report it would not be a warning sign. The other ones are considered warning signs. Urinary frequency, leaking fluid, vaginal bleeding, and heartburn or epigastric pain with a headache.
the
Urinary.
first one.
So urinary frequency is a normal thing that happens in pregnancy.
Leaking fluid.
Leaking
Yes.
fluid before she's term would be concerning. Vaginal bleeding is concerning. Heartburn or epigastric pain accompanied by a headache is usually something we could see with preeclampsia. What are the 5 P's affecting labor?
Power.
Passageway, power,
Passenger.
position, and
Passenger, passageway, power.
Position.
Passenger, passageway,
psych.
And psych.
psychological.
Pain is not one of the 5 P's.
Yeah, no.
Passenger, passageway, all the things you said are correct. And so this one said which one is not? Pain is not. So passenger, passageway, power, position of the mother, and psych are the 5. We talked about gate control theory. Fetal heart deceleration caused by uteroplacental insufficiency.
Late decelerations.
They're late.
Yep.
So even though veal chop has it as P for placental insufficiency, it is still can be affected by the uterus because the vessels are passing through the uterus to get to the placenta. So uteroplacental insufficiency is going to still be the same thing. This is going to be late decels. We talked about upright positioning for descent. We did biophysical profile. What would not be recommended advice for a pregnant client with constipation?
Strain.
So what's that?
Don't strain.
Don't
Or to
strain.
strain. Am I saying that
Or
right?
to strain would not be
To
recommended.
strain would not be recommended.
Gotcha. Yeah. So basically, what would be recommended with constipation?
Ambulation.
Fluids,
Fiber.
Eat,
High
eat
fiber.
high fiber diet
Okay.
and vegetables.
Good. Mineral oil, castor oil, and enemas are not usually things that we suggest pregnant women do. If
And they
this
love
is
that
something, yes, they do. If this is something that is going to be recommended to them, it would be by the provider in extenuating circumstances. This isn't something as the nurse we would tell them. Because things like castor oil can cause some women take it to try to induce labor, actually. But if we're taking it for constipation, it can induce labor, which is not necessarily good. And those labors are very messy with a lot of diarrhea. And those babies, mom gets really dehydrated. There's a lot of reasons why it's not a great idea. So if she was being recommended to do those things, it would be from the provider. We do, so Amory said not straining. So using relaxation techniques, trying to avoid, or not void, but trying to give her body the opportunity to go every day or on a regular schedule instead of trying to kind of hold it can help decrease constipation. Ambulation, high fiber diet, hydration, all the other things you guys said are good. What should be the first intervention to try with an abnormal fetal heart tracing, whether it's a late or variable decel?
Move mom.
So position change helps both of these for different reasons. Why would the position change help with the variable decel?
Because
The cord compression.
yeah,
Taking pressure off the cord. Why would it help with the late decels?
the head position.
Not quite.
So oxygen gets through the placenta. To get
So
the
moving mom with late decels can decrease supine hypotension and vena cava syndrome. It's going to shift the baby off of mom's vena cava. So position change is a good first choice for either of these. But remember, on the late decels, then we have all those other things to consider. So if you think about point, position, oxygen, IV fluid, notify provider, and tocolytics and turn off oxytocin. What's a tocolytic what's a tocolytic? What does it do?
Tachycardia.
Tachycardia is the side effect for the one that we're going to use for this. A tocolytic is something that slows contractions down. So we talk about tocolytics. We really only talk about one tocolytic for fetal with this one, and that's terbutaline. We'll talk about more tocolytics in relation to preterm labor in week 6. But we have 4 medicines that slow down contractions and 4 medicines that make the uterus contract. Tocolytics decreases the contractility. Uterotonics increase the contractility. So next week in week 4, when we talk about postpartum, we're going to think about medicines that make the uterus squeeze. For our patient who's having late decels, I might want to slow contractions down, and so I'd need a tocolytic. And the tocolytic I usually use for this is terbutaline. And Sarah's correct that the side effect of terbutaline is causing tachycardia. Okay. Which patients might benefit from dietary consult during pregnancy to help with nutrition?
Diabetics.
Teenage moms.
Ones that are
Teenage
anorexic.
moms. Okay.
Or just obese in general.
Diabetics, adolescents. Also, it is a good idea if they are obese, that's a good idea for them as well. But also our patients that have very specific food lifestyle, like vegetarians, certain ethnicities that have very specific cultural diet, things like that, also would benefit from making sure they're getting all their nutrients that fit into, is to make sure it's fitting into what their food decisions are. Sign that labor may begin soon. We talked about bloody show. Talked about that one. What statement indicates the client might be entering stage 2 of labor? What's the second stage?
10 centimeters to birth of baby.
Yeah.
So what might she be experiencing if she's entering the second stage of labor?
Her contractions getting closer. She might feel like she needs to push.
Yeah.
The bear
I feel like I
down.
have to push.
Push down. Okay.
Yep. Sometimes I feel like I'm going to poop. That's really a lot of times what they say, or I feel like I have to push. Nurses reviewing fetal circulation with a client. The client understands the teaching when the statement fetal oxygenation occurs through the placenta. I was like, I don't know what it's getting at. So we already talked about this. The placenta is really where that's like the lungs for the baby, because the baby's not using their lungs. So all of the oxygen comes in through the placenta and then goes through the cord to the baby, and then the carbon dioxide comes out of the cord from the baby to the placenta and goes out to excretion from the mom. And this is why, since oxygenation occurs through the placenta, if the placenta is not perfusing well, then that's why we worry about hypoxia for our baby. True labor. What kind of signs might we see that a patient is definitely in labor?
Change in the effacement, is that how you say it? In the cervix?
Yeah,
Dilation.
cervical change for sure.
Yes.
Dilation and effacement. Let me see what the answer is. Okay, so this one didn't have cervix changing as the answer. So other things we can see that are good indicators of true labor. So we're really going to know for sure if the cervix is changing. But in our patient, if they're having pain in their lower back that's radiating to their abdomen, that's usually labor contractions. Women who feel their contractions like on the upper part of their abdomen Those usually Braxton Hicks. And then also if their contractions improve with activity, so we talked about that with a different question earlier, then that's not usually labor if it improves with activity. If she gets up and walks and we give her some fluids, maybe we just have her drink some water and she takes a warm bath and her contractions are better, not labor. If they're feeling worse, they're not improving with comfort measures, that's probably also labor. The cervix is 2 centimeters, 50% effaced and -1 station, and the fetal heart tracing is reactive and reassuring. What nursing action would be appropriate at this phase and stage of labor?
Stage 2.
Maybe have her sit upright to help with gravity of baby coming down.
Okay, where are we at in labor? What
One,
phase
stage
and
one.
stage are we?
Stage one.
And what phase?
Latent?
What phase?
Is it
We're in the
latent?
latent phase. So sitting upright is a good idea. Ambulating is a good idea. If the baby looks on the monitor, then we don't have any reason to continuously keep her on the monitor. We don't need to check her cervix every hour. We don't need to make her pee every 1 to 2 hours. And we don't need to assess fetal heart tones every 15 minutes. So there is a policy that exists at whatever facility you're at that gives you the best idea of how frequently they want fetal heart monitoring. But in this latent phase of labor, we might just listen to baby like once an hour or once every 2 hours, depending on the policy. We definitely don't need to do very frequent monitoring for this baby yet. So encouraging her to ambulate is the best choice here. We could also, if she's uncomfortable, we could do things like the tub, the shower, massage, gate control theory, all the things we talked about. We have a pregnant woman admitted to the birthing unit, is described as having contractions for several hours, which are now 5 minutes apart. Upon examination, her cervix is 5 centimeters dilated, 80% effaced, and the fetus is in the right occiput anterior position at -2 station. Her membranes are intact. Based on this data, the most important or appropriate nursing intervention would be to, let me see what the choices are. Either encourage her to ambulate or take a jacuzzi. Suggest that she try and nap between contractions. Send her home until she's in active labor, or encourage her to rest in bed. What do you think we should do for her?
What was the first one?
Encourage her to ambulate or take a jacuzzi. So like get in the tub.
I'm stuck between that or rest.
If she's not in true labor, then she can go home.
That's what I would say.
Well, she has changed her, so it looks like, let's look at it again. She's already admitted. So, I don't know like she must have changed her cervix from the previous exam because they admitted her. She's admitted on the birthing unit and is having contractions for several hours. But now they're 5 minutes apart and her cervix is 580 and -2 and the water's intact.
I mean, she's
So
in
I think
pain.
that's cervical change for her.
She's in pain. She's about to not sleep. So that's why I was thinking rest, but she hasn't had her, what do you call that when the thing comes out? Water broke? Her water hasn't broken yet, correct?
Her water's not broken.
I guess she can do the jacuzzi. That's what they do at Baptist.
Yeah.
So the best choice for her was going to be to ambulate and take a jacuzzi. She's probably not resting at this point.
Yeah.
And so we're not going to suggest a nap. And we don't necessarily want to put her in bed anyway, unless she's asking to rest in bed, because now we want her to be up and walking and encouraging her labor to progress. We're probably not sending her home. She technically isn't considered active labor till she's 6 centimeters, but she's 5 centimeters and 80% effaced. I don't think she's not delivering today. If she was 2, I'd send this girl home. But this one, probably she's staying, so ambulating or taking a jacuzzi is a good idea. A woman in labor is 5 centimeters, 80% and -1. Station, the baby is left occiput posterior. The most appropriate nursing intervention to promote comfort and facilitate progress of labor is, hold on, choices. Having the woman assume a hands and knees position. Encourage the woman to sit in a jacuzzi. Apply counter pressure to the sacral area, or helping the woman ambulate during early labor.
Not early.
Is it hands and knees?
So
Or
this
is it a
one,
squat?
hands and knees. So squat might also help, but so the baby is left occiput posterior. So the baby's, the back of the baby's head is more towards mom's back. And so putting her on a hands and knees position can give the baby some room to rotate to try to turn to OA, because that's going to be a better way for the baby to flex and come through the pelvis. I don't actually disagree also with green. Apply counter pressure to the sacral area, because women with an occiput posterior baby have a lot of back pain. And oftentimes we do counter pressure in the sacral area. But the question said not only to promote comfort, but to facilitate progress of labor. And the counter pressure might help promote comfort, but it's not going to help with progress. But hands and knees can give the baby room to kind of move into a better position. So hands and knees is going to promote progress. Woman is 6 centimeters dilated in 0 station and contracting every 4 minutes, and she wants an epidural. Oh, we talked about this one. We're going to give her flu bolus. The cervix of the woman is dilated 9 centimeters. She states that she has the urge to push. Which action should the nurse implement at this time? Is it okay for her to push right now?
No way.
No.
So what should we do?
Maybe breathing exercises.
And blow during contractions. So we're going to have to really work with her for this last hard part. This is also, what phase of the first stage could this be considered right now?
What stage? Like second
What
stage?
So we're still in the first stage, right? Because second stage happens when we're fully dilated.
Oh, yeah,
Remember
right.
that in the first stage there were phases. There was the latent phase, and then there
there's
was some other
active.
phases.
Is it?
Active.
And then
And then we give consideration to something else that happens right at the end of the first stage. This is called transition.
oh
yeah.
And transition is happening right at the end of the first stage of labor. And this is this scenario. She's 9 centimeters and has an urge to push. And we're really working with her with panting and blowing and focusing her breathing and not bearing down yet until she's fully dilated.
What does pant blow look like?
So we'll do.
Sorry, let me look at you. Where are you at? Oh,
Sure.
Okay.
The thing with these little pants is that it actually kind of lifts the diaphragm off of the top of the uterus a little bit to give them a little, maybe a little relief, a little less pressure. Truly, there's a lot of different types of focused breathing exercises you can do with your patient. And usually those ones where they're this close and they're really having a hard time focusing, I'll use that during the peak of the contraction. But in between, I'm having them do more focused breathing where they're breathing in through their nose, blowing out through their mouth, so that we're getting good oxygen to the baby. Because with pant and blow, that's going to help during the peak, but then they can really quickly switch to a very strong hyperventilation pattern And then they feel bad. They get like numbness and tingling around their lips and dizzy and lightheaded, and it can affect oxygenation to their baby. So just kind of any type of focused breathing that helps them stay in control for that last little bit until they're ready to push and they enter second stage is going to be helpful. Any other thoughts or questions? We've been in here for a long time.
No, I'm good.
Okay, I'm going to stop our recording if I can find my mouse. There we go.